Well, wonderful. We're going to get started with this next session, and this is going to be screening and interventions during the lifespan of a Fontan-Kreutzer. The co-moderators in this table is Dr. Gaurav Arora, who is essentially directing electrophysiology at our institution, and Libby Lanford. And Libby is an expert advanced imager here in Pittsburgh. So the first speaker is Dr. Arvind Hoskoppal. Arvind is director of the ACHD program at UPMC, Children's Hospital and Heart Vascular Institute. Arvind is associate professor of pediatrics, and we are very happy to have recruited him a few years ago from Utah. Arvind will be talking about approaches to Fontan-Kreutzer management program. Welcome, Arvind.
Thank you for the kind introduction, Dr. Kreutzer. It's an honor to be here and speaking in the symposium, and thanks to my co-directors for putting this together and inviting me. I'm not just honored, I'm also humbled to be here. We didn't know, but it was such a great surprise to have the OG of Fontan-Kreutzer procedure, Dr. Kreutzer himself, grace us with his presence. And to all the attendees all over the world, both in person and virtually, my heartfelt gratitude. And I promise this is going to be the only non-clinical talk of the symposium, and I've been posed with talking about setting up a Fontan-Kreutzer management program. So I'll give it a shot. Let's go. So why do we need to have a Fontan-specific program? What is the scope of the problem? As we all know, we heard multiple times, it's been more than 50 years since this procedure was conceived, and now there are more than 70,000 people worldwide living with this circulation, and this number is increasing. And here in the United States, most of the adult Fontans are taken care of or should be taken care of in an ACHD program. And there are only 50 accredited ACHD programs and about 120 self-identified ACHD programs in the country, and 320 board-certified ACHD physicians. That may sound like a lot for 70,000 in the world, but in the United States, but we have other ACHD patients to take care of. More often than not, a Fontan patient is probably less than 10% of our practices. But these patients are extremely resource intensive, and I talk about the 80-20 rule, where 20% of your patients take up 80% of your time, and that's not a hard and fast rule, but this probably fits the definition. And hence the need for specific Fontan management programs. And data are evolving. I was talking to Dr. Lanford earlier today, and she's one of our Fontan management people, and she said, I've been doing this for a long time, and in the 1990s, we didn't have treatment for PLE. We didn't have treatment for plastic bronchitis, but this is evolving, and we are learning, and we need to have specific programs designed for this patient population. Now, a Fontan circulation is inherently not a perfect situation. It is a palliation. So I think this was Goldstein who described this as the human-made form of heart failure. Like right from the get-go, there are issues. And though this is a small percentage of our population, the comorbidities are higher than any other population. There are data to prove this, perhaps the highest. And it is not just the heart that we need to worry about. The Fontan patient it's a multi-organ system disease. So in addition to the heart, we need to look at the liver, the lymphatics, the lungs, kidney, growth, brain, contraception, pregnancy, etc. Most of these are covered in today's symposium. But that constitutes a real Fontan management program. And if we have a fragmented approach taking care of these patients, this can lead to late detection of comorbidities and poorer outcomes. And the ultimate pathway for these patients would be transplant timing and listing. I believe that session is coming up later today as well. I talk about transition because no good Fontan management program is complete without having a good transition program. I say that term loosely, that it is more, in many institutions, it's more of a concept than an actual program. But I don't think there's a perfect transition program, but these are some of the concepts. Because why do we need to have a transition program specifically for Fontan? Because we know there's kind of like loosely put, a bimodal peak of comorbidities right after, in the early post-op period, where a pediatric cardiologist is taking care of this patient, and during the transition phase in the adolescent to the early adulthood. So extremely important to have a good transition program. And where we gradually shift the responsibility of healthcare management from the family to the patient. And if I can get a show of hands of how many Fontan patients show up by themselves to clinic even when they're in their mid-20s, and even 40-year-olds are showing up with their parents. And I see a lot of nods in the audience, and that is true. And in addition, like, there is this vulnerable period where in the teenage where there could be a lull in their comorbid issues, and they're feeling great, and they don't want to come and see you anymore. And by the time they come, there are data to show that they're sicker and harder to manage. So I'm just going to run you through some thoughts about what you could do. There's no perfect recipe for a perfect Fontan management program, but screening protocols are important. It not only ensures adequate testing, but paradoxically, it avoids over-testing. So if you have a protocol in place and not a one-size-fits-all kind of situation, but obviously there are nuances to that, but protocols are important. And those quote-unquote multidisciplinary Fontan management clinics, these have several flavors as well. And a single physical clinical space, and there are some institutions which do that, but logistically this has become harder, and especially during the pandemic, I'll show you a list of subspecialists who are needed to take care of these patients. It may be near impossible. So what we do is like a virtual program where we have multidisciplinary meetings where we get the data and review it together with the subspecialists. This is a busy slide. You're not supposed to read all of this, but this is the village which is needed to take care of a Fontan patient. This is from a paper published by the Cincinnati group, and Tariq was still at Cincinnati. He was on this as well. But imagine getting all these people in the same room at the same time to take care of one patient. I don't think it's possible. Maybe they do it in Cincinnati. Sasha is smiling, but he says no either. So, but this is what it takes. But if you look at this list, most of our patients see most of the subspecialists at some point in their lives. So we did come up with the testing frequency in this JACC expert analysis published recently. This is offered as a guide. The one on the left side of the screen, the EKGs, the echo, are pretty standard. Everybody gets that in most clinics. What you want to pay attention to is to the right side of this. This is the multidisciplinary evaluation, the exercise testing, and also surveillance CATs. I don't know if most institutions practice that. In our institution, it is becoming standard of care that most of the Fontans do get surveillance cath, the frequency of which is going to be determined by the cardiologist. This is, again, this is also available in the same expert analysis. It's a little bit more detailed card, which you can easily hang up in clinics for quick reference. You can also create smart phrases to prompt you to do these testing in your EMRs, and available. I'm not going to go through each one of this online because it's available easily. The 2018 ACHT guidelines also divides the ACHT patients, the Fontans, not just based on their severity, which will be the most severe form of congenital heart disease, but also based on their physiologic stage, the so-called AP classification. And again, this is another reference you can use to determine the frequency of testing applied to individual patients, of course. So what do we do here at UPMC? It is, we try to do like a truly patient-centered approach with the Fontan cardiologist kind of excuse me, conducting the orchestra, working with other cardiac subspecialists and other internal medicine specialists. Of course, we incorporate research and social work, which is extremely important, taking care of these patients. We have a virtual multidisciplinary model in our program, and we do have a standardized testing and follow-up protocols. And we have this called Fontan sheet, which not only serves as a clinical guide, but also as a database when taking care of these patients. This used to be a PDF format, an editable PDF format with, I'll show you an example in a little bit, and then where our nurse coordinator enters all of these and updates the sheet and hands it to the cardiologist prior to seeing the patient. And in addition to all of this, this can be easily handed to the patient as part of their medical passport and an easy guide if they're either moving or seeking care elsewhere or in times of emergency. Now we have evolved into a dot phrase in our Epic EMR, and which half of it is automatic and half of it is manually entered. And we can walk you through that if anybody's interested. And this is kind of unique to UPMC, led by the Adult Heart Failure Group, the MOC. It's not maintenance of certificate, and everybody's getting a little nervous. It's MOC's Medication Optimization Clinic, which is an intense 6-week program where we have been referring some of our Fontan to, where they get the counseling, the medication optimization labs, and because there are data in the adult heart failure world to show that escalating therapy, we see a Fontan, we see them back in 6 months, change one medication, but here this is a 6-week course, quite intensive to escalate the therapy to the full so-called GDMT. And we do have a monthly multidisciplinary meeting where we review all the data, and subspecialists are invited on an as-needed basis. This is a screenshot of how the Fontan sheet looks like. It was initially conceived for the liver data and liver follow-up alone, but now it has evolved into like a comprehensive 4-page PDF document where it's a one-stop shop for all the latest labs, cath data, cath imaging, and it is modifiable, of course. If somebody wants to add additional features, we can do that. As I said, now we have evolved into an electronic format of this, and this is, you can create an encounter in Epic, and it's called an informational encounter, and have a dot phrase, and where some of the macros are auto-imported, but the rest of them are tabbed through sections, and this is highly customizable, and I find it extremely useful, and then you're not looking for the sheet in a database. It's right there in the EMR, and it's a permanent part of the medical record system. So as we head into the future, and the idea of a physical combined clinic is resource intensive, and the best model, to be quite honest, is yet to be determined. Like whether it is a hybrid, it has to be a combined clinic, or everything in between. With the pandemic, one of the good things that came out is we got better at using the telehealth platform, and we have been using this increasingly. It's not just to see the patients, but also to also have the multidisciplinary conferences on the Zoom or Teams links. And again, since this is such a nuanced field, we do highly recommend that there should be regional centers and centers of excellence where these patients should be taken care of in collaboration with other regional providers, of course. This is our wonderful team, and Anita is right here, and Natasha, our other cardiologists, and we have social work. We have a dedicated researcher and our own scheduler, which, as I said, takes a village to take care of these patients. With that, I'm going to end, and this is the contact information. I believe we're taking questions at the end. Yeah, thank you.